So let's move on to our next part, the case discussion. Dr. AShish Reddy is going to moderate. Dr. Rupin Shah, Dr. Vineet Malhotra, and Dr. Siddharth Nagireddy. Can we have them on the stage?
Thank you, Dr. Ramasamy, for giving me this opportunity. Case 1, this 35 years old male is presented with secondary infertility. Is married to a 27-year female. The female workup was unremarkable, and he has 2 kids from the previous marriage and a history of vasectomy 4 years back. Physical examination, absolutely healthy appearing, and genital normal phallus bilateral testis was 20 cc in size. His labs where the testosterone was normal, FSH and LH were normal. How to proceed from here?
This is a fairly straightforward case. Wife is young, vasectomy duration only 4 years. High probability of being able to do a proper vasovagal. So he would be counseled for a vasovagal. We would tell him that IVF is an option, but for him vasovagal would be a better option with a 90% probability of success.
Semen analysis showed azoospermia fructose was positive, and so vasostomy or vasoepidermostomy?
So when one does a vasectomy reversal, the fluid coming from the testicular end has to be examined for sperm. If sperm are present, that rules out a secondary block. If sperm are not present, despite lavage and milking, then that would indicate a secondary epididymal block, and then one would do a vasoepididymal.
So I'm going to throw a little bit of a, make it not straightforward. So the couple has come from an IVF clinic to you. They have been told that vasovasostomy will likely not work, anti-sperm antibodies will form, so even if Dr. Rupin does the surgery, you're likely not going to get pregnant naturally. So instead of wasting the 80,000 rupees on Rupin's VV surgery, why don't we just take the 3 lakhs and do the Tessa with ICSI? So how would you counsel this couple? Now they're already thinking they're going to get sperm retrieval from you. Now you're telling them, I want to do 80,000 and vasovasostomy.
No, I tell them both options are equally valid. And I would discuss pros and cons. I think it's very important. So Ranjit's question is very good. I think at every stage, the surgeon has to overcome his bias, the ART specialist have to overcome their bias, and present all options, in this case, both options in a balanced way. Probability of success during surgery, advantage of surgery, disadvantage of surgery, benefit of ART, and let him decide. And I've seen couples go both ways. So it's perfectly fine. We don't have to insist that only vasovagal. We don't have to deny IVF if they would prefer that. But we also need to make sure that they know that both options are valid.
And so who's the ideal candidate for...
Assuming that the female partner is young in this case, 27 years, her ovarian reserve is supposed to be good, and assuming that. And some people have even a long duration post-vasectomy, the chance of anti-sperm antibodies, but it is only 4 years, even if you take it that way. Probably this case should go to the andrologist for the vasovagal anastomos, which has got a good success rate of 90%, as I was saying in his lecture.
So 4 years duration, vasostomy?
Any duration you can explore because, okay, so I think that again is linked to vasovagal can be done by even a general surgeon, but because while doing a vasovagal you might need to do a vasoepididymal. Somebody who is competent in vasoepididymal, which is a much, much higher grade of surgery, should be the person doing a vasovagal. So anytime you're doing a vasovagal, you should be prepared to be able to do a vasoepididymal. Yes. Secondly, antibodies don't really matter. So there are many studies suggesting that even antibody positive cases could achieve a natural pregnancy in the vast majority. Thirdly, supposing the wife had been 35, That is where a more closer dialogue with the female counterpart would be required. What is the follicular count? What is the AMH? What is the potential for waiting? Will we be harming? And then take a combined decision.
Who is a straightforward candidate for an ICSI, sir?
Who is a?
Straightforward, like directly.
This was a straightforward candidate.
No, for ICSI.
Oh, for ICSI.
Yes, sir.
A couple where, in general, the wife is 35 plus, or if the wife is younger but AMH is plummeting, or if they're very stressed out and they want a pregnancy as soon as possible.
So, ICSI outcomes between TISA and EPISA?
Makes no difference.
Same. So, what methods in VVA?
This is very technical. Anyway, vasovasal could be 1 layer or 2 layers. It depends on your skill, but primarily it depends on the discrepancy between the two ends of the vase. If the testicular end tends to enlarge over time, if the testicular end is very large and the urethral end very narrow, 2 layer will do better. If there's not much discrepancy, which can happen if there was a sperm granuloma, which was allowing release of the pressure, then a 1 layer is equally good. And as I said, whenever you're doing a VVA, you have to be prepared to do a VEA also.
So how much, if the gap is more, if they've cut large amount of vas, like do we need to mobilize?
So that's a good question. He's asking if the gap is more. One of the factors that will determine the success of a vasovasal is how the vasectomy was done. Sometimes the surgeon does the vasectomy on the convoluted vase, and then there are 2 very different kinds of vase which you're trying to join together. Or sometimes the surgeon just pulls the vase and goes snap, and one end is at the inguinal ring and the other end is near the testes. And those can be very tricky because you can mobilize and join them, but the man's testes will ride high up. So whenever we do a surgery, we try and identify where is the nodule, what is the gap, and if there's a very big gap, that may be sometimes an indication to head towards IVF ICSI rather than do a surgery where his testes would then be very awkwardly positioned.
Yes. So when to do a follow-up semen analysis?
We do it every 3 months up to 1 year.
Okay. When to consider it's a failed
If it's no sperm for a vasovasal, if you've not got sperm up to 6 months, probably it's not going to happen. For a vasoepididymal, we wait up to 1 year. I had one patient who 3.5 years after his surgery phones me up from UP. Dr. Saab, I heard something moving in my scrotum. I'm saying, oh my God. And after that, I got a semen test done, and I said, oh, what's the use? And now the count is 14 million. So, but 1 year is a minimum that you need to wait, and that's what we counsel the patient.
Right. The next case is a 30-year-old man. He has come to OPD with a 25-year-old wife. Was complaints of primary infertility with 2 years of duration, and wife evaluation was unremarkable. And his physical examination, he was a healthy man, normal phallus, bilateral testis was around 15 cc. Bilateral vas is present, and bilateral epididymis is turgid. So penis is normal. Labs, morning testosterone was 540, FSH and LH were normal. How to proceed on this case?
Yeah.
What do you ask next?
Yeah, this is the case probably if the turgid epididymis is normal hormones and the female relatively young. So there can be an option for the surgical management.
Yeah, yeah. So next step again, we will ask for a semen analysis. In that, volume is 3 ml, fructose is positive, and it's azoospermia. So what do we ask next?
Yeah, several things in the history in the examination. We want to know if there's been a surgical procedure in the past, if there's any history of STI in the past, because that will tell us in terms of this obstruction, is it an obstruction amenable to correction, or is it something that may not? And if he has a scar in the inguinal region, has had a hernia procedure, or has had history of a hydrocele procedure, I think already mentioned, those are less amenable to correction. Tuberculosis leading to tubercular epidermolysis, and then a turgid but nodular epidermis, you know that's not something that's going to be amenable to correction. But otherwise, with this report, possible STI or no STI, a lot of times you will not get that classical history. Then you are possibly looking at a correctable procedure.
So his repeat semen analysis also again, it was azoospermia. So do you propose CETRAS?
This is good. So normal volume semen with pH which is alkaline and fructose positive is not going to be a block which is before the level of seminal vesicle, so after the level of seminal vesicle. So you're not looking at other corrective conditions, which is why you don't need a truss for him.
So
that is important because too often we see a truss being done when the volume is 3 ml, 4 ml. A truss is required when the volume is less. In Indian patients, less than 1 ml, but otherwise less than 1.5 ml. Normal semen volume, do not do a truss. And if the truss says query ejaculatory duct block, but the semen volume is 3 ml, it's a wrong report.
okay, sir. So provisional, so it's an obstructive azoospermia. Like how do we proceed from here? Vasoepidermostomy.
So if your clinical diagnosis is certain, you don't have a, your most likely block is at the epidermal level, and we don't do a separate vasography in such cases. Hence, we will proceed with exploration, identification of the area of block. At that time, not a vasography, but we use saline to see if you get a free flow in the urethral end, and then proceed with a VEA at the most distal part of where you find sperms.
So now here a variation can creep in. Yesterday you heard it being said very clearly that there is no role for a diagnostic biopsy. This is one situation where if clinically you're very sure, but if you think it is obstructive, but the patient says, Doc, I want to be sure before you take me up for reconstructive surgery, we may do 2 needle aspiration biopsies. One goes to the pathologist, one goes to the IVF lab. Pathologist tells you normal spermatogenesis, IVF lab says many sperm found. The IVF lab will freeze the sample, and now we can counsel the patient that we've proven normal spermatogenesis. You have 2 options. You could proceed for IVF with the sample that I've already frozen, or we can take you up for vasoepididymal with all the pros and cons. If you're very sure that it is obstructive, you may tell him that I'm 95% sure, never be 100%, so we could explore directly and that would save you the biopsy. But this is one scenario where even in the guidelines, biopsy could be an option.
Okay.
No, you don't do an epidermal aspiration because you want to avoid injuring the anastomosis area. So as mentioned, you will do a testicular aspiration to prove.
Yes. So again, what type of suture materials do we use?
So this is a 2-layer anastomosis, and we use 10O and 8O ethylon, and in fact the suture number for the 10O, which is a double arm short thread, which is 3313 suture that we use for the anastomosis.
Okay. So coming to the third case, it's a 31-year-old male. He came to OPD with a 28-year-old wife who has complaints of primary infertility with 3 years of duration. Wife's evaluation was unremarkable, and his physical examination, healthy appearing, and a normal phallus, bilateral test is 16 cc. Bilateral vas is present, epidermis is normal, and penis is normal. Next exam, labs, testosterone, FSH, LH, everything within normal range. Now, what should we ask the patient to get done? Semen analysis. So, volume is 0.5 ml. Fructose is negative. Azoospermia. What is the management?
Now, because it's a low volume ejaculate, so we need to know the fructose is negative. So obviously there's an obstruction. So if assuming that the clinical examination you have said the vas is felt, so probably you need to do the truss and see where is the block.
Next step again, so the truss has been done, and there was a midline cyst of 2 centimeters, and ejaculate ducts both are a bit dilated, and seminal vesicles again dilated, what should we, what is the next step?
So maybe we have to counsel, and I think the sir will, but before Harry told us, but maybe if I see this case, definitely we need to refer this case to an andrologist who's competent of dissecting that midline atrial cyst, because these are the cases with good programs, as sir was also mentioning in his lecture. So not the cases where the block has come because of tuberculosis or the infections, where the midline cyst is really got an excellent program. So I think Dr. Ranjit sir has presented in one of the fertility sterility videos with Dr. Hemendra Shah when he was at Miami, where he has presented a video with laser resection of that midline prostatic cyst. So I think sir will give a more.
So,
I mean, this is pretty standard and you get good results. The question arises whether you do a resection, whether you do an incision. All you've got to make sure is that there's no restenosis. And usually if you've done adequate incision, that's enough. You can use cautery, you can use laser, you can use all forms. The only concern is you don't want a closure of that tract. You'll get sperms. I mean, we inject methylene blue into the seminal vesicles prior to the procedure, and then we incise, and you can just see a gush of that methylene blue. You can check the fluid at that time. You'll see plenty of sperms. In fact, in the next evaluation that you do, you will see plenty of sperms. The concern also is not to do too much, because one of the adverse outcomes of a procedure is epidermoarchitis, and you don't want that to happen in a post-operative scenario.
So just a few technical points. In this case, it will not be a TURED of the ejaculatory duct. It will be a deroofing of the cyst. Both the ejaculatory ducts will actually be opening in the cyst, and when you deroof the cyst, it will drain. If there was no cyst but ejaculatory duct obstruction, then we would have to open the ejaculatory duct, in which case the incision is not in the midline, but on either side. You probe the ejaculatory duct opening and cut from there, which is a much harder and technically more difficult procedure. The point that Vineet made for the surgeons in the audience is very important. Don't overdo it. If you overdo it, there's a possibility of urinary regurg, and we've had a successful TURED where then it resulted in epididymoarchitis, so one has to be very careful there.
So again, the success rate of TURED or...
So if it's a cyst, very high, it's very easy.
For ejaculatory duct obstruction.
Not a cyst, but an isolated ejaculatory duct block, it really depends on the extent of the block. In many cases, the entire intraprostatic segment is fibrosed, and then the SV are dilated. There you will not succeed. Yeah. So it's very individual.
So the complications of TURED, again, retrograde. Yeah. That's it.
Thank you.
Thank you so much.
So, do we have any questions on this? Yeah. Can you please, somebody give the mic there?
Low volume ejaculate, acidic pH, fructose negative. Most common is CBAVD. The case that was presented, that's rare. So even if you think you found the VAS before subjecting that patient to a truss, go back and re-examine to make sure that that VAS was present before you put the big ultrasound probe.
If we have done vasovasal or vasoepididymal anastomosis and repeated SA after 3 months, so, and we find sperms, do we have to freeze the sperms, or we can just reassure the patient that come down after 6 months and you can try naturally?
So this is an excellent question, because there are different outcomes when you're looking at vasovasal versus vasoepididymal. If you've done a vasovasal, you'll usually only expect one directional, which is improvement. You rarely get a restenosis there. But if you've done a vasoepididymal, it will depend on whether you've done a conventional fistula versus whether you've done a ductular anastomosis. In the ductular anastomosis, you will expect to have improvement, but in the fistula, you will actually have a serious chance of restenosis, as sir mentioned in his presentation, and it would be a good idea to freeze sperm there. You would have actually, so freezing actually doesn't make too much of this thing, because we freeze sperms when we do the procedure primarily at the time of VVA or VEA,
surgery.
because that's one of the things, again, as mentioned, we do as a protocol.
There's one more question there. Take this. Take this. Can you come
Thank you. It was very nice presentation, sir, and the case discussion also. As a general gynecologist, I am concerned regarding, apart from primary infertility, in this last case we have discussed, what history should be asked to the male partner so that we can go for physical examination before going for that ultrasound and all? What physical exam means, what history we should ask to the male partner? Apart from infertility, what other complaint do the male partner has?
Other complaints due to the ejaculatory duct block or due to what?
Yeah, due to ejaculatory duct block, that cyst in the... yeah.
That can get quite complex. With ejaculatory duct obstruction, they could have stones in the ejaculatory duct, so the presentation could be painful ejaculation, it could be hematospermia, and of course infertility. So sometimes the presentation is not infertility, but the other two symptoms.
So he must have painful ejaculation. That
Not must, he could
have.
may have painful ejaculation, especially if he has a stone in the ejaculatory duct. Or he may have blood in the semen because of infection related to the ejaculatory duct obstruction.
Okay. And if it has any cyst, that...
Cyst per se by itself doesn't create much of a problem. The problems come from the infection of the calculi.
Thank you, sir.
Culture positive, treated with antibiotics, and persistent semen culture positive. This is one scenario. There is an asymptomatic person, culture positive, culture negative. So how to proceed in those two case scenarios?
I'm assuming the second one also has leukocytospermia,
Yes,
which
both
is significant.
the cases leukocytospermia, symptomatic, asymptomatic, culture positive, culture negative, and persistent culture positive, despite antibiotic therapy.
No, so you have to understand, you have to differentiate between STIs and bacterial infections. Now, when you look at STIs, you will not grow them on any culture. So then the treatment for persistent leukocytospermia as per guidelines is that you would treat for STI, give doxycycline. If you've got bacterial infection proven by, say, a post-prostatic massage culture or a bacterial culture, which means you have urinary organisms, which are most commonly Enterobacteriaceae, then you're going to treat by culture-sensitive antibiotics. So you have to treat them as culture negative, because you've got to do an RT-PCR otherwise if you're going to look at chlamydial infections, which most of us will not end up doing, but treat empirically based as an STI, because you did not grow an organism, and then you're treating as an STI. But if you're treating it with a culture positive, you're not looking at it as an STI, but rather a urinary organism.
You have given 6 weeks course, again repeated culture. Do you repeat culture? If repeat culture is positive, what will you do?
Now you're looking at a culture positive infection. So we've taken away the STIs now, and we're looking at bacterial. Now this is also common. You've got someone that's just been treated again and again and again, and then the IVF fertility center tells you that every time we do a culture, it's still positive. One of the things that I want them then to do is repeat a sample in clinic, because then they have to follow the protocol of how a cultured sample should be taken, which means urine is passed, the skin is taken back, you clean with betadine, you make them pass urine, and then you take a semen culture sample. If they've done that appropriately and still have a growth, then it's the laboratory methods, which means that they're going to make sure that in the lab, then we do a short cycle of antibiotics just pre-ICSI, and in the lab, then they manage with the control.
Is there any role for testicular sample? Because most of the infections will come in the extra testicular ductal system, either seminal vesicles levels or at the prostatic level. In this case scenario, can they go ahead with that? So still data is insufficient in this matter.
Yeah, I don't think there's a recommendation for using testicular for this.
So there have been several studies, interesting one. In one study, they did a vaginal swab and culture, semen culture, vaginal culture on the day of IVF. 80% of the cultures came positive. There was no difference in the pregnancy rate. So there is some suggestion that a positive culture may not matter. But a lot of embryologists quiver and shiver at the thought of bacteria entering their culture media. So if the IVF lab is concerned about the culture, then one could take testicular sperm. You take a step back, routine semen culture is actually not recommended prior to IVF, though many centers do it, and by doing so, they then land up in trouble. Lastly, if you have persistent sterile pyospermia, this could be an indication for antioxidants because the pus cells will release more ROS.
So I think we close this session now. We'll have a photograph. Amit sir, please come. Ranjit sir.